Good afternoon. I'd like to thank Dr. Tate and the organizing committee for inviting me to give this talk. We'll talk this afternoon about malignant polyps. I think it's an everyday dilemma that we encounter on what to do with these polyps and how to best manage our patients. And I'll try to go through all the evidence and present a flow chart to help guide us how to best treat these patients. Okay, so malignant colorectal polyps, as I said, are an everyday dilemma. They're not that common, but every time we encounter one, it raises multiple questions on which way we should best, what's the best approach to help our patients. So we'll start off with the definitions. A malignant polyp is a colorectal polyp that contains histologically invasive cancer, which means the cancer cells extend beyond the muscularis mucosa into the submucosa. It's a T1 cancer according to the TNM classification, and obviously there is no invasion of the muscularis propria, which would make it a T2 cancer. The depth of the submucosal invasion can be further divided into three layers: superficial, intermediate, and deep submucosal invasion, SM1, 2, or 3. Or what's more common perhaps today is to divide it to superficial and deep according to the 1 millimeter depth cutoff. Now we can talk about risk stratification of a malignant polyp during endoscopy. Now, in the last few decades, there's been substantial evidence and advancements in technological advancements regarding optical imaging and optical biopsy, if you would, with magnification or not, which enable us to classify polyps. We can use older classification variables such as size and location, or we can look most closely at the topography or morphology of the polyp. We can dive deep inside and look closely at the pit patterns and the vascular patterns of the polyp. And we also have other clues, which I will go over, and we'll talk about whether additional imaging can help us in this process. However, if your margin is less than 1 millimeter, then you should follow up with surgery. The most current NCCN guidelines, which were updated just a few months ago, but really there is no different from the ones published in 2017. Again, the look at malignant pedunculated or sessile polyps. And if you are able to remove the specimen in a single piece, if it's pedunculated, then definitely you go to observation. If it's a sessile polyp with invasive cancer, then you have an option to observe or to go to colectomy. And this is mostly based on the pathological variables that we have discussed, including tumor grade, presence of vascular invasion, or tumor budding. However, if you have a fragmented specimen or the margins cannot be assessed because the polyp was torn or the edges are burned by the diathermy, then you need to complete oncological evaluation and go on to colectomy. So if we try to summarize what we're talking about, so we have pretty good evidence on the fact that accurate endoscopic classification and risk stratification can be performed today in expert centers, and this should be done prior to every advanced resection, especially when a malignant polyp is suspected. We know that we can use several histological variables which are associated with poor outcome to predict if we need further oncologic surgery, or we can settle for endoscopic treatment. And when we have favorable endoscopic and histological variables and a complete en bloc resections, then we know that the outcome is similar to surgery, and we can safely recommend follow-up for these patients.
Just with the biopsy force of like. So, Michael, we faded out there on your talk. We don't want to stop listening, but so we can go back to listening right online on the GIEQs live stream menu, catch up, and then his talk is right there on the Thursday at the end of the program. So I'd like to round off this session by thanking everybody, thanking Dr. Stephen Heitman, Dr. Amir Klein for his great talk, especially thanking Professor Michael Bourke in Sydney, and catch up with him, and thanking my co-moderator, Professor Ralph Bishops. Thanks very much for joining us in this session.